Welcome to the Explainer. Today, we're tackling a really high-stakes topic, one that's a cornerstone for your anesthesia exams, the emergency laparotomy. Look, this is a procedure where every single decision counts, so having a structured approach is absolutely key, both for keeping your patient safe and for nailing your exam.
So let's just start with a number. A pretty stark number, actually. 15%. Just let that sink in. A few years back, that was the 30-day mortality rate for patients having this surgery. A number like that, well, it screams that something has to change, right?
And that's exactly it, isn't it? That huge mortality risk is why this whole area has been under a microscope for quality improvement. It's also why, your examiners are going to expect you to know these evidence-based pathways like the back of your hand. It just hammers home the point that being systematic here isn't just good practice, it is absolutely critical.
All right, so here's how we're going to break it down. We'll look at just how big this problem is, what happens before surgery, the core anesthetic management, what comes after in critical care, and finally the big picture pathways that are making things better. Think of this as the perfect structure for your exam answer.
Okay, section 1. First things first, let's set the scene. Before you can manage the risk, you've got to understand just how big of a deal this is. So what are we talking about with an emergency laparotomy, and why does it put so much strain on everyone involved? And the numbers, they're pretty staggering. We're talking about 30,000 of these procedures every single year, just in the UK. And the cost? Over £88 million a year in intensive care alone. So yeah, this is not some rare, once-in-a-career thing. This is a common, messy, and expensive emergency that you're definitely going to see.
And why are these happening? Well, it's a whole mix of things. You can see here, almost half are for a blocked bowel. But then you've got really life-threatening stuff like perforations and peritonitis. And the patients themselves? They're often elderly, pretty frail, and they're not just coming in with this one acute problem. They've usually got a whole list of other health issues too.
All right, on to our next section. And this is so important because, honestly, the fight for a good outcome, it starts way before they ever see the inside of an operating theater. It's all about taming the chaos, right? Taking a patient who's spiraling downwards and starting to get things under control. And the absolute key thing to remember here is that these two things, assessment and resuscitation, they have to happen at the same time. This is not a one, then the other situation. You're trying to figure out what's wrong, doing the exam, looking at the bloods, the lactate, the CT, while you are actively treating the problems you find. It's a real juggling act.
And for a lot of these patients, they're septic. So your playbook is the Surviving Sepsis campaign. And listen, these aren't just nice-to-haves. These are proven, time-critical actions. We're talking antibiotics in within the hour, fluids going in, getting that blood pressure up, and then, the most important part, getting them to theater to fix the source of the problem. It's all about beating the clock.
Okay, so now we're in the theater. This is really the heart of the matter, especially for your exam. What do we actually do to get these incredibly sick patients through the surgery itself?
And this quote from Nat 4, it says it all really. The biggest anesthetic cause of death? Aspiration. In a planned surgery, the risk is minuscule. But here, in an emergency, it's a very real danger. So, number one job, without a doubt, is to secure that airway. And do it fast.
And the way we do that is with a rapid sequence induction, or RSI. The whole point of an RSI is to make that vulnerable period, the time the airway is unprotected, as short as humanly possible. But you have to be careful because these patients can have a massive drop in blood pressure when you give them anesthetic drugs. That's why you'll often reach for something like ketamine, or at least have your vasopressors drawn up and ready to go.
Okay, let's talk about fluids, because this is like walking a tightrope. It is a really tricky balancing act. If you give too little, their organs don't get enough blood flow. But if you give too much, well, they get waterlogged. Their lungs can fill with fluid, and it can even mess with the surgeon's work.
So because it's such a tough call, we've moved away from just guessing. This is where goal-directed fluid therapy, or GDFT, comes in. The idea is to use advanced monitors that tell us about cardiac output to guide us. And for your exam, you've got to mention the FlowELA trial. It's the big one that's looking at whether this strategy really makes a difference for these specific patients.
And while all of this is going on, you can't forget about the lungs. We basically steal the playbook from intensive care here. We use what's called protective lung ventilation. So smaller breaths, lower pressures, all to prevent damaging the lungs and causing more problems down the line.
Right, the surgeon's done. But our job? It's far from over. In fact, this next phase, postoperative care, is just as critical.
the journey for the patient continues. Pain relief is obviously huge for recovery, but here's the catch. We want to avoid just pumping them full of opioids. Why? Because they can slow down breathing and make the gut sleepy. So the modern approach is opioid sparing. We use a cocktail of different things, maybe a regional block like a TAP block, maybe infusions of things like lidocaine or ketamine to get on top of the pain without all the side effects.
And a massive part of this phase is simply getting the patient to the right place. The national guidance on this couldn't be clearer. If a patient's predicted risk of dying is over 10%, they go straight to the ICU. No debates. That's a fundamental standard of care you need to know.
Okay, so we've talked about all these little pieces of the puzzle, but how do you put them all together? How do you make sure every patient gets this level of care every single time? Well, that's where we zoom out and look at the big picture. And the answer is through national projects, like the National Emergency Laparotomy Audit, or NELA. This was a total game changer. What NELA does is collect data on every single one of these surgeries across the country. This means hospitals can see how they're doing compared to everyone else, and, more importantly, it drives them to adopt these standardized, proven ways of doing things. And this is what it looks like in real life. NELA set up some really clear rules. Things like, you must calculate their risk score. If the risk is high, a consultant surgeon and anesthesiologist must be there. The surgery has to happen quickly, and the sickest patients go straight to ICU. It's all about making sure the highest risk patients get the A-team every time. So, did it work? You bet it did. Remember that scary number we started with, 15%? Well, by 2018, that number had dropped to 9.5%. That is a massive improvement. We're talking about hundreds of lives saved every single year just by being systematic. So the big takeaway here, the thing to really remember, is that having a clear, consultant-led plan that covers the patient from the moment they hit the door until they recover, it just flat out works. It transforms outcomes. And that really makes you wonder, doesn't it? Where else could this kind of approach save lives? And that's our look at the essentials of managing an emergency laparotomy. All this info comes from a great BJA education article from 2019. Get your head around these pathways and you'll be in a great position. Good luck.